All right, guys. So in this module, what I want to talk about is when we have to use non-resorbable membranes, meaning we have to go back and get them. And the type of membranes that I like for this purpose are made from Osteogenics. It's a great company. They don't pay me to say that to you. It's important for you to know. I never ever recommend anything to you because somebody throws me a bone. It's just not how I roll, as they say. So it's exactly what I use, and I pay for them just like you do. So at the Institute, when you're taking teeth out, there are going to be times where you can't get primary closure, when you can't get the tissue from the buccal to the lingual to seal. That's what primary closure is. So what do? This becomes your new best friend. This product is called cytoplastic. This product is called cytoplastic TXT 200 singles. And how you use it is as follows. This is important. You're definitely going to end up using these at the course. So I'm not sure it's going to show in this camera because it doesn't even show sometimes to my eyes unless I look really carefully. But you get used to it and you'll know which side is the sheeny side. And it's the side I'm holding towards you right now. Why is that important? Because this side goes facing the defect, goes away from you. Remember in the earlier video when I told you about Memlock, the resorbable membrane? I told you it doesn't matter whether you put it this way or that way. This one does. You want the shiny side. It has everything to do with porosity and has everything to do with what we're trying to achieve. This is a very sophisticated and helpfully engineered membrane, and it's going to help you tremendously. This is how we use it. Now, I'm demonstrating this to you in the anterior mandible because it's all I have right this second. But you're going to use this, quite honestly, everywhere in the mouth on a single site extraction. So let's go back. What do we have here? What are we doing? This is a tooth that you extracted. It's a 5-wall bony architecture when you're done. That means you didn't break off any walls, and it means pathology didn't destroy any walls. So for years and years, honestly, the protocol was just put bone in it. I remember Carl Misch saying, you don't have to even put anything in a 5-wall defect. It'll still grow bone back very nicely. And maybe that's true. But the technology it changes every couple of years, and the leading clinicians in the world use the method and protocol I'm about to share with you. So if we're extracting a tooth that we might put an implant in, I said just might, you're going to graft it with Mineros, and then on the top of that, you would place this with the shiny part of it away from you. And you want it to be, it's pretty easy to do on this model, but you want it to be 3 millimeters past the edge of the buccal or lingual bone. And you can kind of see it how I have it right now. Now this is buckled on me a little bit. I would flatten this out with a molt elevator. So again, obviously this is in the incisor region. Let's move it for a minute back. Let's assume for a moment that we have teeth that we just took out a molar. So that's exactly how it would go. And when you finish suturing this, it's perfectly okay that the white portion is exposed to the oral cavity. That's the whole point. You don't have to hike up this gum and change the vestibule, right? If you stretch this gum so that you got primary closure, If you stretch this flap, then you've picked up and affected the vestibule. And you'll have to go back and do an apically positioned flap. But with using this membrane, which is so beautiful, that's why it's tremendous, and you can leave it exposed. You would do this on a first molar, on a second molar, maxillary, or mandibular, it doesn't matter. And I will tell you, it's very tempting to skip this. But here's the beauty of it. It is the state of the art right now for taking out posterior teeth or anterior teeth. And I have this flapped, but clinicians are using this even if it's not flapped. So they're going around after the tooth is extracted and they're carefully freeing up the buccal mucosa and the lingual mucosa enough, and you can cut this, by the way, but you want it to go over the occlusal socket by at least 3 millimeters on each side. And then you would end up sewing this with probably a cross X stitch. And then you come back anywhere, in my case, anytime after 3 weeks without anesthesia, and you can just lift it off. And it'll be immature tissue underneath, and you're in a totally different position than if you had to get primary closure. It's a tremendous non-resorbable membrane. It means you got to go back and get it. And by the way, if it looks perfectly, if it looks really good at 3 weeks, sometimes I wait 6 weeks before I take it out. It doesn't hurt the surgery in any way. So again, this is a single site non-resorbable membrane, and you're going to use it in the institute when you come here. And all you got to know is this is what it looks like. The shiny side, it goes down away from you, and it'll be very apparent to you when you're here. Okay, and you will be sewing around that. Now, one more. What if you have a big buccal defect? And, I don't know if this has happened to any of you. For years on the buccal defects, all I used was the Memlock that I demonstrated on earlier videos. But what can happen with that is it can cave in. So the buccal, when you go back to place an implant, you have a buccal concavity because the membrane didn't hold its space. And that's why they came up with a non-resorbable membrane that if you look closely, well, you don't have to look that closely, it's titanium reinforced. So when I'm using these, it's usually for a pretty significant defect that we've created or it was there. Doesn't matter. So because it's really important to hold that space. And again, there's some room to cut these on the edges. So, don't expect that you won't be doing that. So you can cut and customize to any shape and size you desire. I will tell you there's one more thing that's important. When I'm using a non-resorbable titanium reinforced membrane, I tend to want to keep them in place, and I don't think that the tack system that I've showed you in other videos is adequate. What I tend to use is another kit from Osteogenics called Profix. And you're going to be using this at the course. And what's really nice about this system is that it does not require any drills for these are screws, these aren't tacks. And they come in all kinds of lengths, 3 millimeters to 6 millimeters. And you don't have to have a drill to screw this in. It's self-threading, which is a huge, and anything that speeds up your surgery and is predictable is what you're going to hear from me. Okay, so the fact that I don't have to use it, because 10 years ago you would always have to use a pre-drill that went with the screw that you're screwing in. And so I think with the non-resorbable membranes, because you got to remember something, these membranes are going around bone. There's bone underneath this. And again, what I tend to do is tack in one side around the defect, lift it up, put my bone in the defect, bring it back down, and then tack in the other, whether it's the mesial or the distal. And another thing I should point out to you is that you have to create a little divot, a little hole, either with a high-speed drill. I actually have a rubber dam punch that we use for our rubber dams. I have several of those that I use, and you're going to be using them in surgery. And their only purpose is to create a little hole here, because if you screw the Profix screw or any system you're using, it tends to catch your membrane, and it's very frustrating. It gets all curled up, and you don't want that. You want it to be passive and lay there. So the way to do that is what I do is I put a rubber dam punch hole in the membrane where the screw's going to go through. It's very, very important little tip there that you're going to want to know. So again, the larger the defect, the more work we have to do. The bigger the flap we have to make. The more preparation we have to use. I mean, what's the point of grafting if it doesn't achieve the outcome that you're after? I mean, why not work a little longer and use the products that are there that are predictable in front of us, so that it's a beautiful thing. And I know some of you have experienced it. You're certainly going to experience it after you come to my office at the course, that when you go to remove the membrane, which obviously in this case is going to require a full appointment, anesthetic, a flap to retrieve this. This is different than the single site over a socket that I showed you earlier, because this one, when you go to retrieve it over a socket, we don't even have to numb the patient. We take the sutures out. If it looks really good, I don't take this out at that visit, because I take the sutures out at 3 weeks. And you're going to be using both resorbable and non-resorbable sutures in this course. And I have a periodontist on staff who's fabulous with suturing that'll help you if that's a weakness in your skill set. But when we take the sutures out, if this looks really good, I leave it another 3 weeks. And I don't have to numb them. I just use a collared plier. I grab a little edge. It does not hurt them. And I lift this out. This, on the other hand, is screwed in. And be sure you document that you screwed it in and where you place the screws. Sometimes I take a photograph of it. And this requires a flap. And you wouldn't be doing this, by the way, for, in my case, 16 weeks. Because, and again, this does not require full primary closure. So it's a great way to reach predictable outcomes, which is what this is all about. So they're the membranes we're going to be using at the Institute. Memlock, which is resorbable. Cytoplast 150, which is non-resorbable. And Cytoplast titanium reinforced membranes. By the way, they have other shapes and sizes, but the point is that we're going to be using resorbable, non-resorbable, some without titanium and some with titanium. You know, and in some cases in the course, we might even use a pure titanium mesh. So it depends on the size of the defect and what our goals are. And that's what the purpose of you coming here is, because it can be overwhelming. When you have these in your hands and you're doing numerous patients, as you will over that weekend, it doesn't become as obtuse as it may seem right now. So I look forward to sharing every gem plus a lot more when you come in. But I wanted you to be familiar with products that I know you're going to use. You're going to use the Profix screw system. You're going to certainly use the BioHorizons tack system. as well as a lot of other products that don't require a video before you meet me. Looking forward to seeing you guys soon. Stay well.